Good afternoon, everybody. Thank you for coming. It is my pleasure to present today, and I would like to thank everybody, speakers, and the audience. We decided to do this honestly for two reasons. The first one is to get some update, and the second reason is to get to know a lot of people that we've known them probably just by pictures, and we've never seen them. So it's good to have a social gathering as well. So today I'm going to present cardiomyopathies with thick walls. Basically, a lot of things can give you thick walls, but out of those, left ventricular hypertrophy is one of them, cardiac amyloidosis, hypertrophic cardiomyopathy, and renal failure, glycogen storage disease, Anderson-Fabry's disease, and Friedreich ataxia. For the sake of time and what is most common, I would just go over two of them a little bit. The first one, I'm going to give it as a case. So this is a patient we saw in Mubarak, 66 years old female, history of hypertension, AFib, hypothyroidism. She's known to have gastritis, recurrent admission with fluid overload and pleural effusion. Literally, she was admitted probably 8 times with the same symptoms. Every time, fluid overload, pleural effusion, echo normal, EF is 55. So she keep coming to the internal medicine, and probably she was admitted, 7 times or so. So this time she was admitted with recurrent nausea, again with fluid overload. Her ECG, I don't have it, but it was AFib with low voltage, and heart rate is reasonably controlled. As you can see, the X-ray bilateral pleural effusion. So this is the echo. As you can see, pretty much very thick, wall. You see the thickened mitral valve as well. This is the short axis. You can see there is a hint of a pleural effusion, still thick wall. And I would say this is very classic. You pretty much can see everything on the diagnosis here. So you can see the valve is thickened. The septum is also thickened here. You can see a little bit. I don't know if it's the best view, but the cavity is not big enough, and biatrial enlargement. Low tissue Doppler velocity on lateral and medial annulus, and you can see the IVC is very blunted and dilated, non-collapsible IVC. So this is classic. Again, this is a strain image you're probably familiar with. We don't use it routinely, but this is one of the one of the top reasons you should use strain image, because it has classic finding, and this is what we call a cherry on top, or bullseye. So what is out is they decrease the strain pattern, which means the muscle is not moving well, but this one is completely normal. So you see this red on top of this purple. This is classic for the diagnosis that we're going to talk about. This is not the patient ECG, but this is also a classic low voltage criteria. You can see it here. You can see a pseudo-infarct pattern on the anterior lead. You can see a poor R-wave progression going all the way down to V6. So the diagnosis is indeed cardiac amyloidosis. So from this 2020 scientific statement from the American Heart Association, transthyretin amyloid cardiomyopathy is not rare. For 3 different reasons based on this scientific statement, we need to talk more about cardiac amyloidosis. The first one is non-invasive diagnosis. In the past, we have to do biopsy. A lot of people, they just shy away from doing the biopsy, but in 2023, you do not have to do biopsy in most of the patients with cardiac amyloidosis, especially ATTR. The second reason is we are underdiagnosing this. As Dr. Farouk just spoke about HFpEF, a lot of them, they have the diagnosis of cardiac amyloidosis, but we don't do our job diagnosing them. And to be honest, the echo I just showed you for our patient, as classic as it gets, this was done at least 2 years prior to the presentation. So the echo I just show you, this was from 2 years prior to her presentation, and to be frank, it was not in our hospital, it was in a different hospital. But again, anyone can miss this diagnosis. And then the third reason, which is probably important, is the FDA approval for a new treatment for the cardiac amyloidosis. So nowadays it is a treatable disease, and we should try our best to diagnose those patients. So what is cardiac amyloidosis? Cardiac amyloidosis, basically the way I think about it, the squeezing function of the heart, there's a starch. You just think about it, something is going into the muscle, so the compliance is affected by that. So basically it's a deposition of a misfolded protein that is normally secreted by the liver, and this will deposit in the heart and will lead to a cardiac dysfunction. You have a stiff muscle. So the liver here, normally have the transthyretin, which is a protein that dissociate, and then if there's any misfolding, this will be amyloid fibrils that will go into different parts of the body, but mainly we're talking about the cardiac amyloid. It is life-threatening. It's not something easy that people will die from it, so we have to pay attention to it. So how do we diagnose and how do we define cardiac amyloidosis? So first of all, as we said, it's a protein infiltration of the myocardium. We have a restrictive cardiomyopathy because of the starch or the fibril that is attached to the muscle. Then we have two different types. The one that we should refer to the oncologist is the light chain, which is very life-threatening. It is very serious thing. So people can die very suddenly, and you should just pay attention to that. And then you have the TTR protein, which can be either due to a genetic mutation, the variant, or it could be the wild type. Now, all of them can give you a lot of complication, including neuropathy, nephropathy, GI, and orthopedic issues like bilateral carpal tunnel syndrome, severe back pain, and so on. But with AL, you can get the nephropathy, which is unique to AL and usually doesn't come with the ATTR. On the other hand, the orthopedic issues is mostly with the ATTR cardiomyopathy. So, the work of the diagnosis, honestly, like, okay, I'm suspecting someone to have a cardiac amyloidosis, what should I do? It is on the guideline, there is a stepwise approach. The first step, based on the history, ECG and echo, that is first step. Everyone should get an ECG, everyone should get an echo, and based on the history of HFpEF. Then what you need to do is the monoclonal light chain, which is basically kappa and lambda-free light chain, and the immunofixation assay. This usually, at least in Mubarak, it takes 1 or 2 weeks. I think at the KCC it's a little bit faster. But in general, instead of waiting for the result, what we decided to do, we do simultaneously the PYP, which is basically technetium pyrophosphate, and this is done by the nuclear physician. So the first step is you do the monoclonal light chain. If it's positive, then we are good. You just send them to the your favorite oncologist, Dr. Ahmed Alhajri. He's in the KCC. He's seeing a lot of those patients. But basically, if you have a monoclonal light chain, then you have to do the biopsy to rule out cardiac involvement. But let's say if you don't have any monoclonal light chain, then you do the PYP, which is diagnostic for the ATTR. Then if it's positive, it is ATTR. You have the option of doing the genetic test to decide if it's variant or wild type. However, if the monoclonal is negative, the PYP is negative, then it's unlikely to be cardiac amyloidosis. So this is a busy slide that I'm gonna just cut it half. So what do we do? Someone who's known to have, ATTR amyloidosis, okay, what should I do? If they have heart failure, basically you just treat heart failure. You just give them the standard therapy that you just heard from Dr. Farouk and Dr. Ali Islami. Now, if you have arrhythmia, you treat them, accordingly. So if they have, AFib, you control them, you do cardioversion, and you decide on the anticoagulation. But the device management is pretty similar for, a validated reason. The issue now, what is the treatment that, we're talking about and FDA approved? So if it's a wild type, then you go with the tafamidis. And, tafamidis is relatively new. It's approved in 2019, I think, by the FDA. The downside, it is very, very expensive. So that is something we should really consider before starting the medicine. Before I forget, our patient was diagnosed indeed with, with cardiac amyloidosis. She was admitted in the hospital. She was in a very terminal stage, and we decided not to treat her with tafamidis because she was so terminal. However, we have a lot of, medication nowadays. The one that is, I wanted to pay attention to it is the patisiran, which is basically the best for the neuropathy. We have different options coming in the pipeline. The only one approved yet is the tafamidis, And it is only for class 1 to class 3. Our patient was end stage and we did not start her on that medicine. And again, even in the guideline, it provides low economic value. So this is something we should consider. And sorry, for the AFib patient, they should be anticoagulated for the AFib. Now this is a criteria that we put together in Mubarak Echo Lab. So if you're suspecting someone, the first thing we do, we send the immunofixation electrophoresis as well as the free light chain, and then we ask at the same time for the PYP. We send them usually to Dr. Saoud Al-Anizi, but excuse me, even our nuclear medicine in Mubarak, they're interested in that, and we'll start sending people to them. The ECG, as we talked about it, and then the echo. This is the criteria that I'm not going to go over, as you probably are familiar, but the first thing is the LV wall thickness increase and the masses increase. Then you have different parameters, which was very classic in the patient I just showed you that was missed many times. I don't know how many times this was done, the echo. So what do we need to know about cardiac amyloidosis? The first one, it's the two most common form is AL and ATTR. We as a cardiologist need to know more about the ATTR. The diagnosis you should have a high index of suspicion, and PYP is only diagnostic if the ATTR or the monoclonal antibody is negative. So if you have a positive PYP with positive light chain, this is AL until proven otherwise. And then the treatment for AL, you send them to the hemato-oncologist. ATTR now tafamidis only for class 1 to 3. This is a website, from the ACC, very nice, topics, and you can just take a look if you're interested. Now, HCM, hypertrophic cardiomyopathy, it's unexplained LVH. Pathological hallmark is the myocyte disarray and fibrosis. They do live, with normal longevity in most of the patient. It is serious with sudden death and heart failure. The prevalence nowadays, classically we said it's 1 in 500, but nowadays are, ranging between 1 in 200 to 1 in 500. So this is not a rare disease. 600,000 cases in the US only. So what is HCM? So the first thing that will you should strike you is the 15 millimeter. If it's above that, you should think about HCM. If they have a family history or positive genetic testing, then we're talking about 13 to 14. For the septum wall thickness. But not only that, if you see a systolic anterior motion on echo, this is something that can be with HCM. Hyperdynamic LV function, hypertrophied apical displacement of the apical muscle, myocardial crypts, abnormal or anomalous papillary muscle, and myocardial bridging. So what's the difference? Dr. Yahya is going to have a whole talk about sports cardiology, but just as a slide to differentiate between athletic heart and HCM. Usually an unusual LVH pattern, and their ventricle is very small, less than 45 millimeter, with marked left atrial enlargement, bizarre ECG, abnormal LV filling pressure, and reduced TDI, and male and female. However, with the athletic heart, usually they have a big ventricle, so it's more than 55, the LV in diastolic dimension. They responded to detraining and supernormal exercise capacity, no scar on MRI. So what is the treatment for HCM? Someone comes in, okay, they have HCM, what should I do? No symptoms, no treatment, all right? So you just risk certify them for the ICD. If they have symptoms, you have to decide whether this is an obstructive symptoms or non-obstructive symptoms. So let's say symptomatic patient with suspected HCM. What should I look for? You should look up for if there's an LV obstruction, you should do resting, provocable, or none. So what is the obstruction? Is it at rest, or you have to provoke it? Then you have to look for, is there a basal septal hypertrophy? Is there, a SAM or something else, obstructing the pathway? Or you have an abnormal papillary muscle location, multiplicity, and laxity. And then if there's no LVOT obstruction, then we're talking about mainly diastolic dysfunction, or sometimes you have a mid-cavitary or apical hypertrophy. And now I want to pay attention for the apical hypertrophy. Unfortunately, not every hospital has the contrast or the echogenicity for the echo, but with apical HCM, it is a must that you should rule out apical aneurysm for a reason that I will tell you shortly. So and symptoms due to arrhythmia, you should treat accordingly. So how do we decrease the obstruction? We should avoid positive inotrope, pure vasodilation, and high-dose diuretic. How do we do that? We do that by decreasing the contraction, increasing the resistance, and increasing the volume. So this is a busy slide that for the management of heart failure with obstruction and non-obstructive HCM. So I'm going to cut it into two halves. The first one is the obstructive HCM. If they are asymptomatic, no drugs, nothing. However, if you have dyspnea and fatigue, what is the first drug? Usually beta blocker is the first medication, then verapamil or disopyramide. If they progress and they are refractory to symptoms, then you have either the alcohol septal ablation, and it is emphasized at experience center, or surgical myectomy. And now, the differentiation, which one to go with, I will go in a few slides to explain that. So if they don't have any obstruction, we have symptoms but no obstruction. Okay, asymptomatic, nothing. If they have fatigue and dyspnea, then if a preserved EF, you use beta blocker, verapamil, and then diuretic as needed. If their EF is low, you treat according to the HFrEF guideline. Beta blocker, cautiously using the ACE and ARB for the effect of the vasodilation, and diuretics. Then ICD for prevention that we'll talk shortly about, and heart transplant. I have 3 minutes. You cannot tell me. 3 minutes. All right. So indication: medically refractory symptoms. For the invasive septal reduction, so medical refractory symptoms or gradient of more than 50, then this patient need intervention. So what favors myectomy and what favors ablation? If the patient had an extensive LVH, if they have a surgical coronary artery disease, and if they have mitral valve disease with the available expertise in both, this favors myectomy. It's been done for a long time now, more than 50 years. The ablation is not new anymore, but if the patient is old, multiple comorbidities, patient preference, then you go with the alcohol septal ablation. This is the primary prevention indication if someone have sudden cardiac death for the ICD here. So the sudden cardiac death, VF or sustained VT, if yes, this is class 1 indication for ICD. However, if you have one of the following, which is massive LVH more than 30, family history of sudden cardiac death, unexplained syncope, apical aneurysm, which is the new kid in the block. This was just added in the recent guideline with EF of less than 30. This is class 2 indication. For the NSVT, the children gets 2A and adult 2B. Significant LGE more than, or late gadolinium enhancement more than 15% on cardiac MRI, this is still 2B. And no risk factor means no ICD. This is just to tell you, if there's no risk factor, no ICD, one or more, you get an ICD. However, the gray area is really something big in the HCM. You cannot convince someone who had, a relative died, and you want to put an ICD for only this reason. So a lot of time it is difficult to convince patient. This is a new medication that was just, in the process. I think it's very expensive medicine. And hopefully, we'll get it in Kuwait, but I don't know if this will be available shortly. Basically, it just, break the myosin actin chain and makes the myocardium more compliant. So it will improve the compliance of the myocardium. The screening, very important for the kids every 1 to 2 years. Adult, they get it every 2 years. Adolescent, but the adult every 3 to 5 years. And this is depending on the family history of the HCM. This is one thing that was just added in the sport and activity with the new guideline. We used to say HCM, no exercise, but this is completely different now. So mild to moderate intensity is encouraged, and it is shared decision for competitive sport. So in summary, or at the end, unexplained LVH is the key for diagnosis. Genetic involvement and information is also important. Management is only for symptoms and tailored to pathophysiology, whether it's obstructive, non-obstructive, or restrictive. And then invasive therapy should be individualized, whether it's septal ablation or myectomy, and new medication is available. Mild to moderate intensity exercise is beneficial for HCM patient, and thank you.